Okay, what else do I want to say about this? I think that should do it for now, unless there are any questions. So the first part of the assignment is come up with a topic statement, brief, as described under October 6th on the first page. If you have any questions what that should be, then make an appointment very soon with your group leader and discuss it. And also you can, with your group leader, brainstorm about possible topics and approaches to that. Any questions? Most of the work now about the term papers will be in your small groups with your group leader. I think all of us have office hours by appointment listed, which means if you want to start discussing this with us, just send us an email and say, most usefully, I'd like to meet with you, here are my available times this week, etc. And list a multiple set of times. Don't just say 4 o'clock Tuesday, that might not work, but if you're available 3 or 4 or 5 different times, it's best to indicate that in your email so that the group leader, including me, will be able to find a matching time. Okay? All right, now let's turn to our topic for today, which is to get back and finish up our discussion of Cochrane's article as part of our look at challenging common sense, and then move on to an overview of the U.S. health system, carrying over this theme of challenging common sense, because I'm going to argue that you may think you understand the U.S. health system, and I am suggesting to you that you may not understand the health system any better than Galileo's contemporaries understood the situation of the world before he re-educated their common sense. So we're going to be pursuing that, and we'll look at some specifics. Let me just summarize briefly Cochrane's major approach and major claims. Instead of using the in-your-face blockbuster technique of the McKinleys, using American data in the model that McEwen had provided for them using British data, Cochrane is much more sophisticated, droll, understated, laid back. And he uses a more sophisticated technique. He is using correlation coefficients in order to bring some things to your attention in perhaps a startling way. What do we mean by correlation coefficients? You have to remember that a positive or negative correlation coefficient is not a value judgment. It is merely a statement about the relationship between variables. The independent variable along the horizontal axis and the dependent variable along the vertical axis. And there are two different basic flavors of them: the positive and the negative correlation coefficient. The positive correlation coefficient is about the relationship that looks like that. As the independent variable increases in value, in quantity, then the dependent variable also increases. The rate of increase is different in every case, and that's the actual number of the correlation coefficient. It's either close to a direct linear relationship, or it's a weak correlation, and that's reflected in the number. It's a very robust correlation, almost a straight line. Those are all reflected in the values of the correlation coefficient, but the sign indicates that this is the basic relationship. As the independent variable increases, the dependent variable also increases. And the negative is just the obvious different case. As the independent variable increases, the dependent variable, as the independent variable increases, the dependent variable decreases. And there are many examples of these. So one way to begin to cut through the very compressed set of data that Cochrane includes in his article is to pick a few in which the associations, negative and positive, seem exactly as they should be. So there are a couple in which the negative correlation coefficient relationship is exactly the way we would think it ought to be in a rational universe. He says, for example, if the independent variable is GNP, or GNP per capita as measures of economic strength, of a particular country, then as it increases, if the dependent variable we're measuring is mortality, then we should not be at all surprised that the wealthier a society is, the lower the mortality is. So the relationship should be a strong, robust, linearly negative relationship. As wealth increases, mortality decreases. No surprise there. As it should be, the world is the way we think it is. Another example that he uses that also seems to make intuitive sense is the number of nurses per capita and mortality. So, if you have a society with more nurses per capita than another, it's not surprising that its mortality will be lower. And that as you increase the number of nurses, the mortality becomes lower still. That's just the way we think the world should be. He also, and there are two places in the article where you can find these relationships. There is a very compressed table in which all this data is sort of compacted. And you have to go very carefully across the lines and columns and so on to sort them out. But it's all there, all mixed between pages 202 and 204, if I remember correctly. And there are also a couple of places, especially pages 20... Sorry. Primarily pages 201 and a little bit on 202, in which he gives you the high points. He sort of looks at his big, robust table, which is on page 202 on the top, and picks out what he thinks are the most interesting relationships that are worthy of particular note. So there are the numbered points. They match the points of the table. You can look at either. And these examples you can find in either place. So those in which the positive correlations seem to make sense by common sense are cigarette smoking and alcohol consumption. These are positive correlations. If there is a greater amount of cigarette smoking, or however this is measured, or alcohol consumption, then if the dependent variable is mortality, morbidity, however the measure, that will increase. This is as we expect it to be. But then he throws in a couple of kickers. Two nutrition-related kickers. And they begin to alert us that something is going on, and he's playing with us and trying to startle us. If you look at sugar consumption per capita and protein consumption per capita, the correlations seem to work in the reverse direction from what our common sense tells us they should be. Sugar is bad for you, right? So the more sugar you consume, the worse should be some measure of mortality. But in fact, he tells us that sugar has a positive correlation. Negative correlation. Sugar has a negative correlation, which means the more sugar you consume, the lower is the mortality and morbidity. That's the opposite of what we think it should be. And on the other hand, we eat protein, that's good for you, but it seems to have the reverse correlation. The more protein you consume, the higher the mortality. Why should this be? How could this be? He's playing with you. He's not going to tell you. He wants you to face these data and their implications and to begin to think in unusual and uncomfortable ways. Let me just give you one possible reason why the sugar relationship works the way it does. That is, the more sugar a society consumes, the lower will be its mortality rather than the higher. It all depends on what your perspective is. These are a number of countries whose data are pooled and synthesized together. Suppose the country at an earlier stage, or some country still stuck in a undeveloped stage, has considerable malnutrition, considerable food challenge. And that's the first stage, low sugar consumption, because there is low consumption altogether. And when you get to a later stage where the sugar consumption, the independent variable, increases, that may mean that you are jumping your caloric intake considerably, you are jumping basic nutriments considerably, and moving from a famine or near famine state, in the first case, to a better nutritional state in the second, as measured by the amount of sugar intake, should correlate with positive changes, that is a decrease in mortality, if that's the measure. Now what about this protein consumption? Why does that go in the wrong direction? Why should increased consumption of protein actually lead to higher mortality or more sickness in that society? Well, I'm going to save my theory. It's a hypothesis. I don't know. I met briefly, but he never revealed the secrets at Cochrane. But he never told us. He kept being droll and making us squirm and think about it, etc. But the biggest anomaly that he presents and seems to take pleasure in sticking in your face is the one that he talks about in several places, but especially on page 204. And that's the doctor anomaly. Here he tells us that no matter what we do, no matter what manipulation we try to do, we cannot get away from the fact that the correlation between the number of doctors per capita and measures of mortality is not the same as for nurses, but the number of doctors per capita as it increases the mortality, as does protein consumption increase the mortality. And he has fun with this. He says we could do this, we could do that, we can make this assumption, but he says ultimately, on the top of page 204, with obvious glint in his eye and pleasure, in general, however, we must admit defeat and leave it to others to extricate doctors from their unhappy position. Now, he's not saying anything so simple and naive as, well, doctors cause death, they're iatrogenic, they're badly trained, they do harm to people. No, nothing like that. And a more sophisticated possibility is that a society recognizes that it has a problem and it tries to meet its problem by producing more doctors, by increasing the budget to medical schools, or founding new medical schools, whatever, to generate doctors and to put them into the population. And he says, well, we looked at that and that doesn't hold up either. There's something else going on that will explain this strange doctor, and I would say related to it, protein anomaly. I see them as really two parts of the same basic explanation. Now, I don't know the real answer myself, but you have to recognize a few basic things. These are not causal relationships. Correlation coefficients are about correlation. Correlation is not causation. It shows that there may be association between variables, but not a direct mechanism that relates them. And in fact, key variables, like numbers of doctors per capita, or protein consumption per capita, might be what is generally called surrogate measures. They're stand-ins, placeholders. They represent a much more complex relationship that is reflected in this number, in this quantity, but is not related to it in an obvious way. And if you begin to let that possibility play on your mind, and remember the multifactorial model, remember the Blum model, remember Blum's emphasis on the critical role of environmental factors, very broadly considered, meaning social environment as well as or more than physical environment, then you can begin to think of some possibilities. And I don't know if this is the answer, but I'm going to put a little diagram on the board that is consistent with the data and makes sense to me. These represent two societies. Well, they're supposed to be the same size, so not much of an artist. Imagine they're the same size, imagine they're really circular. And it's either the same society at two different times, or they're two different societies in comparison. And one society sort of looks like this. There's two doctors, these MDs in little circles, distributed in a population. I want to have 12. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. All right. That means that in this society there are 2 MDs per 12 in a population. Now I'm going to draw another society. Still 12 people, they stand in for millions or hundreds of thousands, whatever. But the number of MDs has doubled to 4. So it's 4 MDs per 12 population. Why might this society with 2 MDs per 12 be healthier than this society? And what kind of society is this? Do we know societies like this? Anyone think it has a familiar kind of look to it? Yes?
I think it represents I think it represents our healthcare system.
How so?
Because like people in the middle have enough money or financial means to access the doctors.
In the middle? Here? But there are no doctors there.
Oh, I thought the
Doctors are all on the outside. I think you may be on the right track, but I think you've got it inverted.
So the people on the outside are able to access
The people on the outside can access the doctors, and they have sufficient wealth so fewer of them will support a larger number of doctors. Most of the people clustered in the middle are without doctors, and they're probably poor. Do we know of any places in our country that are like this? And the answer is damn right. Almost every city. You can see this as the inner city with concentrated poor people without real access to resources, and this less populated suburban ring where wealthier people live with greater incomes and more access per capita to physicians who will generally follow income trends, and where they can make a better living will migrate out and abandon if they once lived in the inner city. So this could be a more equally distributed society, not to say there were no income differentials, but generally a more even distribution in which people of various classes and ethnic groups and racial groups and incomes sort of live together at an earlier time in, say, the history of the city, and physicians were generally dispersed among them and generally accessible. Evolved into a more geographically and professionally segregated society, racially and economically segregated society, much like much of our own, much like the city of Rochester and its surrounding suburbs. And it is no surprise that Rochester has one of the highest infant mortality rates in the country, because the kids who contribute to those infant mortality rates are those in the inner city, and the numbers are extraordinary. And even if the people who live in the suburbs don't have those challenges by and large. Their numbers aren't sufficient to balance against the dense concentration of numbers in the inner city. So what might the correlation of physicians per capita indicate? It might be a surrogate for a segregation, physical, social, economic, in a society. The more doctors it has, the more that society may be differentiated with areas and people of privilege and benefit and high concentrations of people with next to nothing. And that is reflected in the much higher infant mortality measures. How might that also apply to the protein per capita consumption issue? Well, in a society in which the general diet is something less expensive than protein and less difficult to obtain, as in sugar, products that have sugar, the difference between a low sugar intake society and a high intake sugar society might be between a largely malnourished or food challenged society to one in which there is at least reasonable access to at least basic foodstuffs. Whereas a society that has a high concentration of protein consumption might be exactly this society. Because those who can afford the protein, especially the expensive protein of meat and fish and other products like that, are likely to be those living in the suburban ring. And if there is protein consumption in the inner city, it will likely be less, and it might be vegetable protein, that is beans and stuff like that, rather than meat and fish. And it will be a different quantity and different quality. I don't know if these numbers are, if this picture is right, but you come up with a better one that's consistent with Cochrane's very powerful correlation that he is not going to tell us how to explain. I think this is at least logically consistent, and it's also intuitively connected to what we know about our own and other societies that have basic inequities, geographic segregation, social separation, and the like, and that leads to less healthy circumstances than when there is more equal distribution of resources, people, etc. And that's something that the textbook authors talk about when they say, when we find societies or subsets of society in which there is major gaps of income, the mortality and other health indicators are worse than when there are small gaps. It might be reflective of the same reality. So let me just drop that and move on, because we do have to move on. Ponder that, think about it, debate it in your small groups, debate it among yourselves, see if this fits. It's just throwing something out to make us think outside the box. When we think of doctors per capita, we should not be thinking of doctors delivering advanced medical care, science-based, technology-based, and that's all we need to know. The number of doctors per capita might be an indication of a social map, of a geographic distribution, of environment in the broad terms of Xi and Sing. And that's what we need to focus on, not a pipeline of medical science that's going to cure all by pumping doctors and science into the population. That's interrogating common sense. That's thinking about it differently. That's doing a Galileo. And we have to begin to do Galileos on the American health system and do a fresh look at it. It's not easy to interrogate common sense, because the whole point of common sense is that we take it to be real and unquestionable. And if we are told that it's unquestionable and real and true, and that's reinforced constantly, then how do we know to question it? What can we do to break in? How do we know that our interrogation will be successful? How can we protect against deceiving ourselves again, or not even knowing where to look? Well, one of the ways that I think is very effective, and that I use a lot, and will in this course, is to put things in sharp relief by the use of kind of irreverent humor. And so I rely very significantly on editorial cartoons or clever photos that capture an interesting moment. I take cartoons very seriously as an important medium of exchange and communication. I've in fact published articles and a book based primarily on political cartoons and created a narrative and an analytical framework. But the essence, the core of the book are not data and tables, but political cartoons as indicative of changing attitudes and important moments in our political culture. And later in the semester, I'll be making some handouts that are derived from that book. It's published in 2013. And I will be using other cartoons and photographs regularly. If you turn to the handout, the two-sided handout, here is a way in which humor can really begin to jar some of your assumptions loose. One of our common assumptions is that America has the very best health system in the world. Of course, not only does it have the very best health system in the world, but everybody thinks so. We are the envy of the world. They flock to our great medical centers, our great clinics, Mayo Clinic, Cleveland Clinic, and so on, from everywhere in the world to take advantage of our great medical care. Well, these hockey fans at the Winter Olympics in Calgary did not think that the American health system was so terrific and used their view on the American health system to make this very important point in a sports context. I'm sure you don't remember the Calgary Olympics, but the U.S. hockey team did unusually, surprisingly well, and at an earlier round, a semifinal, whatever, beat the Canadian team, which doesn't happen. So this was the reaction of Canadian hockey fans. Yeah, but at least we have health care. Nah, you don't. Nah, who's better? And of course, the world was then put right because in the finals, the Canadians whumped the Americans, as should have been the case anyway, given the skill of Canadian hockey players and it being a national sport there and so on. But this moment, captured here in a spontaneous expression by Canadian fans, tells us that around the world, there's a lot of not admiration for the American system, but a sense of despair and disgust, and how could they do such stupid things? And this will become one of our running themes when we begin to look seriously into international comparisons. People at the level of the common sports fan, people at the head of government, look at America and say, why? Why do you do such bizarre things? It is not that we have the purchase on wisdom and perfection and the rest of the world envies us. The rest of the world in many ways is surprised and in despair about how dumb we seem to be and how wrong we seem to have our priorities. I use cartoons a lot. Here is a cartoon that raises the important question about common sense. Isn't it common sense that our American system, which is based so significantly on private delivery of health care in private institutions, like Strong Memorial Hospital and so on, that's the quality. That's where quality is. It's in the private, entrepreneurial, capitalist, free market system. And we don't stop to think that the very notion of making care, health care, access to it, a private commodity in a market environment which says if you have the resources, you get it, and if you don't have the resources, you don't, instead of being natural and appropriate and the way it should be in a best world, is actually a crazy idea that makes no sense even in our own context if we think about it. So what the message of this cartoon is in the panels is to isolate the private delivery of health care so that if you're wealthy and you emerge from a chauffeur-driven Cadillac and walk into a clinic but greeted warmly at bottom right by the physician, where the poor people are sitting on the sidewalk waiting to get in if they can to wherever they will have access. That's what privatized healthcare is, and we think that's perfectly natural and normal. But what if we had fired services that were based on a private free market system? So that is, if you're in a burning apartment and you didn't have the money to pay the firefighter, then he won't come up to rescue you. So that's a crazy idea. Upper left. Or suppose police were not a public service who presumably took care of security needs and emergencies for everyone equally. There's questions about that, of course, but we won't get into that right now. And in fact, police service, like fire service, was something you paid for, privatized. So even if you've been mugged, you've been stabbed in the back, you won't get a policeman's attention until you come up with cash money. And if you were in a supermarket, instead of having the FDA and federal and state agencies assuring food quality, making sure that what's being sold is not spoiled, not rotten, not germ-infested, and so on, and these are important regulatory functions that agencies of government perform equally for all and are paid for out of tax resources as a public activity. Instead, you had to pay for it. Here's a head of lettuce. Is it good? Pay for the consultant who will then tell you whether it is or not, rather than have it available. These are obviously crazy ideas that privatize fire departments, privatize police, privatize food safety. Why is health care any different? We think it is. Why? Common sense. Of course it is. Is it common sense that makes common sense? Or is it something that we have simply inherited and bought into and never interrogated? And there are those who say, I'm one of them, that health care should be a basic right available to all citizens in the country and not a commodity that you have to pay for either out of pocket or through insurance. And if you don't have the resources, don't have the insurance, you don't get it. And you stay sick and suffer and die. In Europe, they look at America and say, what? This is crazy. Why do they do that? For us, it's common sense. Interrogate common sense. Question it. Push it. Look at it a different way. That's going to be a mantra. Another way to interrogate common sense, of applying humor of nice photos in certain situations or good political cartoons, is to look as carefully as you can with the most rigorous approach you can muster at anything anyone, authority or not, says about the healthcare system. Look at it, interrogate it, question it, and try to discover what might be misleading, misrepresented, imprecise, just a scam, whatever. Look through the rhetoric. And that includes looking through the sometimes careless or opaque statements that even Xi and Singh make. Disclaimer. In general, I think they're excellent. In general, I think this is a terrific, if challenging, textbook. That's why I've assigned it. But they are not perfect, and they make mistakes. And we have to be ready to identify mistakes or errors in judgment or leaps of logic if we find them. So overall, I think that if you start reading Xi and Singh, you're going to encounter a lot of very good statements and presented in a very sophisticated way. Let me just give you a couple of examples from the very beginning of the book, page 5. I'm running against the clock, so let me just identify two statements and we'll pick this up next time. Talking about the American system as a whole, left column, about a third of the way down. The system as a whole does not lend itself to standard budgetary methods of cost control. Each individual and corporate entity within a predominantly private entrepreneurial system seeks to manipulate financial incentives to its own advantage without regarding its impact on the system as a whole. So, that seems to me an extraordinarily intelligent, clever, insightful statement, and I wholeheartedly endorse that. They say below, same column, an acceptable healthcare delivery system should have two primary objectives: It must enable all citizens to obtain needed health care services. And 2, the services must be cost-effective and meet certain established standards of quality. I agree. And I certainly agree with their judgment, which follows. In terms of accessibility to all on an equal basis, and cost-effective, and meet certain standards of quality, the U.S. healthcare system falls short on both these objectives. It is neither universally accessible, not even close, nor is it of high quality and cost-effective. If you think that it is, Xi and Sing tell you it's not, and you better start getting used to their perspective. So I find those are extraordinarily persuasive and intelligent things that they say. Page 7, bottom left column and top of right column. It says that despite the federal programs, Medicare and Medicaid, at that point, that was before the Affordable Care Act, 50.7 million people, or 16.7% of the U.S. population, remained without health insurance. Source, U.S. Census Bureau, very authoritative. And then they continue. Even the predominant employment-based financing system in the United States has left some employed individuals uninsured for 2 main reasons. In many states, employers are not mandated to offer health insurance to their employees. And 2, in many work settings, participation in health insurance programs is voluntary and does not require employees to join. So, these are 2 very powerful statements that in the United States, at least before the Affordable Care Act, we had 50 million people and growing of uninsured, and a significant number of the uninsured were not the unemployed, but the employed, because their circumstances of work, or the kind of work they were doing, did not come with health insurance, and that needed to be fixed. That's part what motivated the Affordable Care Act, to fix those problems. And very quickly, the number of the uninsured in the United States dropped 20 million, from roughly 50 million to roughly 30 million, soon after the implementation. We're going to have to stop here. We'll get back to it. Let's pick up this discussion where we're leaving it off right here.